Hello, everyone, and welcome to the Coram podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is April Kelly. This week, we are with Dr. Ella Corrick. Ella runs our doctorate in health studies at the college. Ella, welcome back to the program.
Thanks very much.
You've been on the podcast before, but for the few of us who don't know who you are, can you tell us a bit about yourself and what keeps you busy?
Sure. So I, as you said, am one of the senior lecturers in the Doctorate of Health Studies program. And my background is I'm a doctor in the north of Scotland, where I work in family medicine and emergency medicine. I'm pretty rural. My family medicine's on one of the Outer Hebrides Islands. And in addition to that, I'm the medical officer for a mountain rescue team up here, the northernmost mountain rescue team in Scotland, Ascent Mountain Rescue Team. And then with the college, I'm also getting involved a little bit with some of the short courses and, enjoying my time with Coram.
Earlier this month, you attended the Special Operations Medical Association's conference for the second year. Tell us about your experiences this time.
I really enjoy the conference. I've obviously been to medical conferences in the UK often enough. And there's something that I really enjoy about SOMA, which is that it brings together people from really, really different agencies and work backgrounds, but with shared interests. So you end up with very, very fruitful cross-pollination of ideas and practices. Whereas in the UK, the NHS can be a bit of a monolith, and so practices are relatively similar, or people are stuck in a particular track for largely bureaucratic reasons, and I feel like there's less freedom to develop and change and grow ideas. Whereas at SOMA, there's people go there really, really open to the different ways of doing things that other people have worked out, and it genuinely feels like quite a productive and exciting way of working. People talk about going to conferences for networking, and I've always felt that word's a little bit anathema to me. It to me kind of brings to mind quite seedy ideas of business people doing backroom deals. But actually, when I go to SOMA, I realise genuine networking of meeting people and learning from things they're doing, things they've worked out, work better for their system or work better for their patients, more importantly. And then you'll find out you've got some niche shared interest, meeting other people from very, very different settings, but who are also doing mountain rescue, for example, but maybe in Colorado or somewhere that gets much, much more significant hot weather or desert environment than where I work. Is so much fun. It's so interesting. And you just get to meet all these really fascinating people.
I remember you and Tom last year, you had some hesitation on coming to SOMA because you were saying, well, we're not SF, we're not SOF, we're not military, we're not. And so now that you've done this twice, do you now believe that you have a rightful place being in SOMA?
Yeah, definitely. I still feel like I'm there as a open-minded person learning a lot, rather than maybe having that confidence to say that I'm bringing something for other people to learn from. But to be fair to that, I did have some really great conversations with people both this year and last, where there were things that I'm doing or places where I work are doing that were useful for other people to hear about. So yeah, I guess I'm starting to feel like I do have a place there.
Even as a special forces guy, I felt the same way. Starting out, I went to 6 SOMAs before I submitted content workshops, and this year was a presentation to give back, to give some of the information that I've seen over the years. So you're not alone with feeling that, a bit overwhelmed as you walk through the doors and you see 1,500 people at SOMA, and many of them are pillars within the community. It's an awe-inspiring experience to walk through those doors and look around.
Definitely.
I feel the same way with the Combat Med conference here in Europe. So it's like the SOMA European version of it. And maybe you and Tom should have a go at that, possibly next year when it's back in Germany.
Yeah, maybe we should. I'll definitely have to overcome some more imposter syndrome and power through to go.
So you said you've worked in mountain rescue. Tell us a bit about your experiences there.
I'm relatively new to my current team. I previously volunteered with a team in the Midlands, Derby Mountain Rescue, And then in the Hebrides, when I lived full-time in the Outer Hebrides, I volunteered with the team there. So I'm still, I suppose, slightly getting to know the systems and definitely getting familiar with our local patch, because we've got an absolutely enormous area that ASINT cover as a team. There's, I think, 26, 28 mountain rescue teams for the whole of Scotland, but our team covers 10% of the area of Scotland. We've got an enormous area, but an area that's not very populated, and it's not as touristy as areas like, for example, the Cairngorms. So we don't get the number of patients and the number of big jobs, but the jobs that we do get might be a 2 to 3 hour drive for most team members. We'll very often work with Coast Guard and make use of Coast Guard helicopters because of the remoteness of our patch. So that's an ongoing learning process for me that I'm really enjoying. And also getting familiar with the team equipment. Every team uses things slightly differently. We recently changed, so we've got 2 stretchers. Previously we were mainly using the McInnes stretcher, which I'm very familiar with. It's a Scottish Highland design, so appropriate that that's what we've been using. But we've now also gained a smaller, lighter stretcher, which is the Titan, and then that presents new problems in itself. How are we going to choose which one to take up the hill? The Titan's much smaller. So anticipating that there might start being some challenges if casualties have lower limb injuries. Thinking about SOMA and things that I got up to there. Just before I went away to SOMA, my team leader and I were talking about whether or not we think we need to start doing some studies and measuring exactly what height of casualty we can physically fit into the Titan stretcher with a Kendrick traction device for a femoral fracture. Because, as you know, the Kendrick traction device sticks out beyond the foot. And I think for casualties much taller than me, and I'm about 5'5", I think we're really going to struggle to fit them onto the Titan. And we were talking about the Slishman traction device as an alternative that doesn't stick out beyond the patient's foot. And then a week later at SOMA, I had the opportunity to meet Dr. Slishman, who, of course, I know you've interviewed on the podcast, and actually directly quiz him about the Slishman traction device. I got to play with one, got to see both. He's got the newer short version that came out, I think, just a few years ago, and the full length version. And I got to get hands on with both, ask the inventor about them, which was such a cool saying. I'm reconnecting.
So tell us about that. Tell us about your experience with meeting Dr. Fleischman and his traction splint. How did that go, and what were you discussing?
Great. So I was just saying it was really great to, sorry about my internet dropping out, downsides of being rural, but it was really cool having this conversation with my mountain rescue team leader about the Slishman traction device. And then a week later, I'm in North Carolina talking to Dr. Slishman and getting to actually get my hands on a traction device. And I was able to get one and take it back so that we can test it out. And I think we've already done a brief test run, but we're going to probably start testing exactly what height of casualty that we're going to absolutely need to switch either stretcher or traction device and do a bit of problem solving.
That's a benefit, isn't it? Because the Kendricks, actually all the other traction devices do poke past the leg, and it must be a mental challenge to try to sort that out on a mountain rescue.
Exactly. I mean, ultimately, we could put some additional padding within the VAC mattress, which is what we pretty universally package our patients in, and have their leg propped up so that the traction device extends beyond the end of the stretcher. But obviously, there's a risk that one of the people carrying is going to bump against the end of that traction device, and that's the absolute last thing anyone with a fractured femur is going to want jostled. Imagine being carried down the hill is not going to be terribly comfortable for them in the best of circumstances, but the whole point of traction, after all, is to try and immobilize that fracture. So we really don't want the end of it sticking out off the end of the stretcher.
I'd really like to hear how it goes for you, and possibly, is that a case study for publication?
Exactly. I'm wondering about, although it sounds quite dry, genuinely very useful for other teams. I know a lot of teams in Scotland use different stretchers, and down in England too. Working out what height of casualty we can fit a Kendrick on versus when we would need to switch over would be quite a useful thing to publish.
Agreed. So you had a chance to meet him at SOMA, and you spent some time on the exhibition table for the college as well. How was that experience for you?
It was good fun. I actually grew up. My parents run a production company, and occasionally I would work on their stall at exhibits, but in a very different context. So it brought me back to my teenage years, but in a very, very different way. It was very enjoyable being there as part of a college that I really enjoy working for. And people come over really interested and chatting about the doctorate program, obviously, was my main focus, but getting to listen in as people talked about the different courses as well. It ends up bringing together areas of medicine I find very interesting because of working rurally. I'm interested in a lot of the austere and remote medicine that Coram teaches on, and it was good fun.
You also spent a couple days at SOMA on the AEC instructor course. Tell us about that.
I feel like I'm at risk of sounding excessively positive, and I don't want to sound like I'm trying to sell something, but the AEC instructor development course was genuinely the best education in education that I've had. It was so enjoyable. I was really surprised by how useful I found it, which is not to understate the amount of respect I have for Sean Keenan and the work he does, but my experiences of mandatory instructor education courses through the context of some other courses has been very poor. In the UK, the Resus Council, in order to instruct on any of their courses, it's mandatory to do the generic instructor course, which is fine for establishing that people are up to a very, very basic mandatory level. But in terms of educationalist theory and quality, the instructor development course for AEC was just in a completely different category. The two main instructors were so clearly passionate about doing good education and would, unlike lots of the other educationalists I've been exposed to, were practicing what they preached and doing really interesting education and shared learning. And it was in a room of people from quite different backgrounds. We had one person there who actually hasn't done the AEC and isn't wanting to necessarily instruct on AEC, but does a lot of teaching, medical teaching for the National Guard, where she works. And she came in, not with any expectations for the course, and I think perhaps feeling uncertain that she belonged there, which is something I can empathise with. And then other people who are extremely experienced instructors and educators from both military and non-military backgrounds, and people, again, not to sound overzealous and positive, but were genuinely sharing something that they're already quite good at in a lot of these cases, sharing tips and interesting thoughts on some of the challenges in clinical teaching, such as how do you give feedback to someone who is already doing something every day in their job, and you're trying to tell them that there's ways that they could develop and improve in it, but they're defensive because they know they're going to have to go back to work tomorrow and do it again, and they've been doing it this way for the last 10 years and it's worked for them. And how do you try and engage those learners to actually listen and let their defensive walls down and hear that you're just trying to help them develop? Those sorts of challenges.
It's interesting to hear your feedback on that. I mean, I attended it as well, and I definitely enjoyed the way that Dr. Sean Keenan set that up. And it's interesting to hear how it compares to the GIC, the General Instructor course found here in Europe.
The benefit we had was this is the first year that I think that they've brought both of the instructors in. One is Kiwi, so he was flown in from New Zealand. One is American, and so none of it was prone, as unfortunately lots of things are now, to how good your internet connection is. We had people all together in a room, which made it very more naturally engaging. One of the instructors in particular is very high energy, a very ebullient body language, which just keeps you awake. And the mix of different personalities and clinical experiences in the room all just added to the interest.
Did you notice a difference between the philosophies of Australia and US and then here in Europe?
I think thinking about practice and education in the UK, although there is a big drive to flatten the hierarchy, and a lot of people feel that we have done so, certainly it's different to 50 years ago when the surgeon might be able to be very disparaging of his non-surgical colleagues. We're not quite at that level anymore in the UK, but I think we're perhaps still a little bit more guilty of putting people with longest experience on the highest pedestal, whereas my exposure through SOMA, at least, seems to be that people genuinely are listening to other people's thoughts and experience and ideas with a little bit more openness and less tendency to put somebody up on a pedestal purely for time served or purely because of their job title. I'm sure there's many, many exceptions to that. Clearly, the military is highly hierarchical, but in the education environment, it felt like people were sincerely open to listening to everyone's ideas as equals and taking them on the merit of their ideas.
The American military has a different view of education, where those of us who are senior NCOs are the educators, and it's very rare to find an officer who will teach. And of course, when you get up to the colonel and general level, they teach themselves, don't they? But for day-to-day teaching, it all falls on the shoulders of the non-commissioned officer.
So maybe that's what I'm kind of sensing, that it's not necessarily about your rank, it's about your capabilities and what you're competent to do and teach.
I remember a couple of weeks ago, you also wanted to experience a traditional American, was it ribs? No, it was wings. Traditional American wings restaurant.
Wings.
And then we took you into rural North Carolina and you had to go. How was that experience?
I enjoyed it so much more than I expected. I don't eat a lot of kind of fried food. I eat a lot of unhealthy food, don't get me wrong. And around here in Scotland, there are plenty of delicious options, but I really enjoyed it, and it was the perfect atmosphere as well. So we were with a couple of people who were either from or currently living in the south enough that they could recommend exactly which things we should try. Got the wings, got some shrimps and grits, and yeah, I loved all of it.
Is there not a lot of karaoke in Scotland? Because I remember as soon as the karaoke started, we kind of made a mad dash for the exit.
Well, there's plenty of karaoke. I just have had the misfortune of never getting to enjoy it, to the shock of everyone present. That was the first time I'd ever been to a karaoke bar or been present for karaoke. So that added to my delightful North Carolina experience. I had so much fun. I could happily have stayed and listened to the karaoke, but I think I was the only one.
That they did start out with the best and the brightest, didn't they?
Maybe the bravest.
I'm curious on the food that you so you talked about naughty food. What, I mean, in Scotland it's deep frying everything. Don't they deep fry Mars bars? But for you, what is that naughty food that you are eating in Scotland?
Well, weirdly, I actually think the unhealthy food that is the biggest staple in Scotland that might not be obvious to other people is mac and cheese. I know it doesn't sound like a stereotypical Scottish food, but mac and cheese is an absolute staple. And my favourite form that I've only ever seen in Scotland is you can get mac and cheese pies. So it's a pastry case with mac and cheese inside. And they're almost ubiquitous in bakeries. And I've, on one of my long runs, we mentioned last time I was on the podcast, I have a habit of very, very long endurance runs, not for any accolades or speed, but just enjoyment. And I was running along the Hebway with a friend, which is a multi-day long distance path. And I had packed very poorly. My dehydrated meals were disgusting. I was massively under calorie. And we went past a bakery and I just bought like a bag of mac and cheese pies. And we were just jogging along the coastline of the Outer Hebrides, just stuffing my face with mac and cheese pies, and it was one of my happiest days.
Ella, tell us about the research that you're cultivating within the college.
Well, the college brings together people, as the name suggests, with an interest in remote and austere medicine. So I'm hoping that because we draw in a very international group of people with that interest, we're generating a field of study that can bring together learning and research into austere medicine solutions that work in different types of austere environments. We do have people who are tactical or military. We also have many people who work in civilian remote and austere medicine. And obviously the patient needs are the same in the different settings, just the way that you can deliver care is going to be different. So we have a faculty and a student body from that really mixed, diverse background. And I'm hoping that we're then going to be able to pursue and generate some really, really interesting work by working together and collaborating on projects that look at different solutions in different settings. What works in one place is very likely to work in another, but it won't always. And it'd be really interesting to look at what does work, why does it work, what are people doing, and what should we be doing.
Plus, we have the ability to do longitudinal research. So, I mean, the bachelor's degree they're doing a capstone study, which will submit hopefully a publishable concept of research, and then they go on and do the masters of osteocritical care, and they'll do minor 3,000 word essays at the end of each module. But they're doing a thesis at the end of that. Is there a way to tie in, especially with the masters and the DHS? How could we tie in some student just going all the way through the pipeline to tie that research into one perfect bundle?
Definitely, we do have that. And I was talking, I suppose, in really broad general terms, but looking at, say, if we were to take one student journey as an example, because of the way the college is structured, we're not presenting people with, here's a named project that we want you to look into. What we're doing is we're saying to people, these are areas that our faculty have expertise in. What do you want to study? And so we'll have students who come in, let's say they're from a paramedic background, who want to look at how their system is dispatching calls. And at a master's level, they maybe are going to do a review of how you can evaluate a system of dispatch. And then they might take that forward into their doctoral program and generate something completely novel, where they perhaps are going to interview service providers in different countries and compare different triage systems, and then carry out a study that looks, let's say, longitudinally at dispatch process. So someone can take an area of interest, and then they will be able to develop a really deep understanding of it and genuinely become a subject matter expert in that field.
It is quite interesting to see how varied the passions are of our students as they come through. We just graduated a master's of osteocritical care, and his focus was triage, and he did a deep dive into that.
Yeah, exactly. We've got faculty with relevant areas of interest and expertise, but the students 100% bring their own expertise and knowledge from their own clinical work as well as the research that they're doing. And it is genuinely a case of faculty and students learning together.
So a broad question I have is, what would your long-term goal be for the college? What would you like to see? What are we missing? Where is the what? So you bring passion into the college faculty. Where do you want to go with this?
I want to see our research output increase, because we do bring together people who work in really interesting fields, and fields that I think are relatively underrepresented in the literature. Whereas I think we could, as a college, create an incredibly interesting research output that is going to generate a lot of collaboration and a lot of interest, I think, with people who work either in related fields or actually people who are practicing in more traditional medical settings could have a lot to learn from austere medicine. I know you do a lot of work in improvised medicine, and improvised medicine doesn't just apply to when you're in the middle of a desert with nothing around. Actually, it's not uncommon that people need to improvise medical solutions in the back of an ambulance in a town. And I think that if we can create more output of research, we genuinely will be sharing some really important knowledge with a much wider audience.
I think that is one of my interests with the journal. So we've been putting out the Compass for ages, and it was a newsletter, and now we're looking at turning that into a peer-reviewed journal. And then Chuba had the idea of the JIM, the Journal of Improvised Medicine. So are we being cheeky by trying to put 2 peer-reviewed journals out in the next year?
Maybe not cheeky, but ambitious.
So somebody who's small, we have 100 students, and we're new. We've been around for 6 years now as a degree granting. We've been around for about 10 years total, and putting out a journal and pushing for research. Are we ready for this?
I think we're totally ready to actually be publishing what we're doing, because we have many people in the college who are established research scientists and long-established clinicians who are doing important and interesting work. The actual logistics of becoming a journal is not going to happen overnight. It takes a long time to meet all the criteria to be indexed, and it takes a lot of work to make your output, I don't know, even things like making sure that it's formatted in such a way that it's very easy for people to access single articles. Sounds very boring, but making sure that you can get PDFs of specific articles and things like that. All of those processes take time, but the actual complex part of the work, the research itself, we're totally ready for.
This is something that we're definitely going to get outside help for putting these journals together, and the goal is spring of next year, so we'll see what happens.
Great, I look forward to it. And as we were talking about, those traction devices earlier, things like that, things that I look forward to publishing with Jim.
There's a lot of research out there that needs to be done on all things austere medicine.
Mm-hmm.
Ella, my final question for you is this: what advice do you have for the new paramedic, the newly minted doctor, the young nurse who's interested in working in austere environments?
I think my advice would be put yourself out there and take opportunities that present themselves. But if you want to become good at something, I think one of the best ways to do it is to notice when you admire the way someone else is doing something. You might be working with a colleague who's more experienced, or who's just worked in a different place, and you think they're good at something. Instead of just thinking, oh, so-and-so is really clever, they're really great at this, give yourself 5 minutes at the end of the shift to think, what did I like about the way they were doing that? And trust yourself to experiment a bit by trying to do things their way. And, maybe it won't come naturally, and you'll flop in that particular style of doing something, whether it's a method of talking to people or trying to order your equipment in a particular way. Allow yourself to take small risks like that and experiment, because that's how you find your way of doing things and become someone that someone else is going to admire.
That's fantastic advice. And funnily enough, today we finished up an austere emergency care course, a prolonged field care course. And one of the Polish paramedics put together an improvised suction device using oxygen tubing and a easy suction EZ, which I've never seen before. And it's precisely as you say. So at the end of the day, look around and learn something from somebody else. And even though I've been in EMS 35 years, every day I'm learning something, and it's quite fascinating to see how much knowledge is out there with everyone. It could be an EMT, or it could be a non-medic, or it could be a colleague, or, as you say, someone who has more experience. And just keeping your ears open, you will hopefully bring in some of that knowledge.
Yeah, exactly. And I think that's what brings, certainly for me, a lot of my enjoyment from my job, is feeling like I'm constantly learning and trying different things, trying to do things in a new way and trying to get better. And that's what gives me a lot of my job satisfaction.
Well, Ella, it's been great to have you on the podcast again. You're a valued member of the faculty, and I really appreciate your time this evening.
Thanks very much.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at coram.edu.mt.